Hello everyone, and welcome to the first webinar in a series being held on vaccinations in the East of England. My name's Harpreet Hockley and I'm the Head of Equalities and Inclusion in the East of England. I want to thank everyone for making the time to join us today, and to those who've already submitted their questions. The focus really for today's webinar is on race and culture, and we've got some excellent speakers joining us today who will cover a range of topics. So we'll be hearing from Dr. Itai Matubike, who will be talking about the science as well as his own personal experience. Dr. Habib Nakvi from the NHS Race and Health Observatory, who will talk about the role of the Observatory in supporting the NHS and also in understanding our diverse workforce and communities better. We'll then have Ruth Adekoya from the regional team on challenging the stigma and making an informed choice, as well as the role of the BAME staff networks in supporting our workforce. And finally, last but certainly not least, Ethel Changa, who's the clinical advisor for the National Vaccination Programme, and she'll be talking to us about reaching and listening to communities and what else we could be doing. We'll then go into a Q&A session where our speakers will try to answer as many of your questions as possible. I want to remind you that this is really a safe space for you to ask any questions that you might have about the vaccination. It might be something you've read, something you've seen, or something someone has told you that's made you think, hang on, I just need to look into this a little more. Your voices are valid, so please feel free to ask anything that's causing you concerns or just something you'd like to explore further. You'll see in the top right there, you've got a Q&A function, so please feel free to submit your questions here. You can choose to add your name, or if you prefer, you can leave it blank. I'll do my best to then group these up and put them to our panel towards the end. So without further ado, let me introduce you to Dr. Itai Matubike, who's a consultant forensic psychiatrist and an executive medical director at Northamptonshire Healthcare Foundation Trust. He's got a wealth of senior leadership experience within the NHS and is an active member of the Zim Health UK, as well as a number of other community organisations. Thank you, Itai. Over to you.
Thank you very much. So before I carry on, I just want to declare a couple of interests here. The opinions I'll express are my own. I've not been paid to do this presentation, and I do not represent any pharmaceutical companies or any governments. So I think the impact of this pandemic is really well documented. We're up to about 2.46 million deaths now. I mean, these slides are from a couple of weeks ago, but every day the death toll keeps on going up. In the UK alone, we're over 115,000 deaths. And these are not just numbers anymore. These are, names that we recognize. These are close members of our families. These are friends of ours. And it has really taken a toll, not just on the economy, but just on the mental health of people's lives in general. So the pressure on the NHS remains really high. Lots of new cases. Thankfully, the number of cases week on week is starting to come down now, but there is still quite a lot of pressure. The impact as well is in primary care, so it's not just the admissions, it's the aftercare, it's the effects of long-term COVID, etc. I just have a couple of reflections, that I want to share with you before I go into the rest of the presentation. I think for me, having the vaccine was probably the single most important thing that I've done. And my rationale for doing it, has been, about myself, my family, my friends, my patients, my colleagues, and just generally, the local community. And I think it was an easy choice for me, to make in terms of the vaccine. I think I was quite lucky in the sense that I did have access to some really trusted sources of information, and that's why that decision was easy for me. It's important to recognize though that there is a lot of mistrust out there of not just pharmaceutical companies, but just a central government in general. People have had some really difficult experiences. There is some well documented historical situations where people of an ethnic minority background have actually been experimented on. The Tuskegee trials, are clear about this in the 70s, the 60s and the 70s. And I think that sort of thing that's happened in the past, fuels quite a lot of mistrust. People feel a little bit pressured and blamed for, being hesitant about the vaccine. And I think, it's important for us to listen to people's concerns, and where there is a number of myths that are out there, it's important for us to sort of clarify that information and really help people make an informed choice, about whether or not they're going to take the vaccine. I just wanted to share with you a couple of, some of my close colleagues who've had this vaccine, people who are from a BAME background, people who are leaders in the NHS. Some of you may recognize Dr. Ananta Dave, who's the medical director at Lincolnshire. And for her, this was really about protecting patients, her loved ones, and looking at her own profile as being someone who was a high-risk group. Edwin Lover, who's a coup at East London Foundation Trust, had the vaccine quite early. The decision there for him was quite an easy one. There are a number of other colleagues, Alenia, who I work with at NHFT, and although she considers herself to be relatively young, she still felt that it was a very good idea for her to have the vaccine, to protect herself and members of her family. A number of other colleagues from different parts of the trust. Fungai, who works, in Barnet, East London, and that, for her, having suffered COVID herself, she really felt that it was important for her to stay protected. Again, a number of colleagues who've, who are from an ethnic minority background, who've also, taken the decision to have the vaccine. So I'm going to cover just a few points, and I'm not going to take too much of your time, but I just wanted to recap on, what COVID is, because it's important for us to understand, what the infection is in order for us to understand, what we're targeting in terms of the vaccines. It's also important for us to recognize that there are a few new variants out there, and the slide deck has changed from the last time that I presented it. COVID is really an acute respiratory syndrome. It causes a severe pneumonia. It's caused by a viral infection. It's called one of the coronaviruses because it's shaped like a crown, and the outside of the virus itself, it's a spherical virus, and it has got a number of T-shaped proteins which are called the spike protein. And it's the spike protein which is the main target for the vaccines which are currently approved, for use in the United Kingdom. There are a number of mutations out there, and I think there will be some concern over, the effectiveness or efficacy of the vaccine based on, how these mutations have been targeting the actual, T-shaped spike protein itself. But I think it's important for us to realize that, even though a virus mutates, that doesn't necessarily mean that the antibodies that we've built to it are completely ineffective. And so it's important for us to continue accessing our vaccines and, ensuring that, our population has got a herd immunity of up to about 90%, because that's what we need to eradicate this deadly virus. So what is a vaccine? I think it's worth pointing out that vaccines themselves are not new. They date back to the 18th century when Edward Jenner was developing, a vaccine for smallpox. They come in various different forms. And basically vaccines are a type of medicines that trains the body's immune system to be able to fight an infection that's not come across before. So what often happens is that whenever you are exposed to an infective disease, your body launches what's called an immune response. And when you do encounter that, infection in the future, your body will have built up what are called, antibodies, and these are basically proteins which the body uses to fight off the infection. What a vaccine does, it mimics almost an exposure to the real infection, whether that's a bacterium or whether that's a virus. And what happens is that, it allows your body to build up these antibodies and, be able to launch a much more robust immune response when it does encounter the real infection. So there are many different types. Some of these are vaccines that you may recognize. Some of the vaccines are ones that are very commonly used in the childhood vaccination programs, and many of the healthcare professionals will probably have had hepatitis B and the flu vaccine on an annual basis, really as a means of protecting one from future exposure to these illnesses. The COVID vaccines, particularly the ones that are approved by the MHRA in the United Kingdom, are new technology. So one is called an Adenovirus Vector, and another one is called an mRNA vaccine. So I'll just explain what these are as soon as I've told you about the different types of vaccines that we've got. So the first vaccine that was approved in the United Kingdom was the Pfizer vaccine, which is an mRNA vaccine. The second one, which is currently available, is the Oxford vaccine. The Mrna vaccine has been approved, but it's not yet in sort of wide circulation in the United Kingdom at the moment. But in terms of the typology or the type of vaccine, both the Pfizer and the Mrna vaccines are what are called mRNA vaccines, and the Oxford vaccine is an adenovirus vector. And an adenovirus vector is basically an artificial virus which contains within it the genetic code or the blueprint of the spike protein. And when that happens, remember I mentioned the spike protein when I was describing the structure of the COVID virus. So that spike protein is that surface protein. And what the adenovirus vector does, it provides the actual genetic code for the spike protein and the spike protein alone. So it's an artificial virus that doesn't cause real infection, but just exposes your body to the surface protein of the COVID virus and allows your body to launch an immune response to that protein and build up the antibodies such that when you do encounter COVID itself, you'll be able to launch a much more robust immune response. The mRNA vaccines, again, slightly different from the adenovirus vector, is that in the sense that they are genetic code of the spike protein, which is not contained within an artificial virus. So basically, all they are is what's called messenger RNA, and messenger RNA is it's the blueprint or the genetic code of this spike protein. Then this messenger RNA then uses your own muscle cells to create the spike protein, and the spike protein is the one that causes you to launch an immune response and antibodies to fight the real virus when you encounter it. It's important to mention that this spike, both of these vaccines, and I don't know if you can see my cursor there, they do not actually integrate with your DNA. So the final common pathway for both types of vaccines, the adenovirus vector and the mRNA, is the release of this a harmless spike protein. The spike protein is that T-shaped protein, which is on the surface, of this spherical coronavirus. And actually, that's where it gets its name, because it looks like a crown with all those T-shaped proteins. And then once your body has been exposed to the spike protein, you then start to develop the antibodies. And there are other cells of your immune system, which are called, the T cells. And these launch an immune response. And when you do encounter the real virus, you'll be able to launch a much more robust immune response. So the key thing here is that it does not integrate with your DNA. It does not replicate within your body, which means it does not reproduce. The spike protein is just a surface protein. It's not the infective, part of the virus, and it's just an ID basically, and a means with which the real virus manages to attach to your cells. But if it's just the protein, it's got no infective elements associated with it. One of the things that's often concerns people is how the COVID vaccines were developed so quickly, and a number of people have always cited that it usually when you've got a new drug that's coming up, it usually takes about 10 years before the drug is first developed and then sort of is tested and becomes widely available. So it's important to say that the MHRA, which is the Medicines and Health Care Products Regulatory Authority, is the body that ensures that none of the medicinal products which are made available in the United Kingdom are at risk of, cause any harm to people within the country. And they have looked at this very carefully before approving any vaccines. So one of the things that happened was that there was that the COVID virus is not entirely a new virus in the sense that it's actually called SARS-CoV-2. There was a SARS, epidemic a few years ago. And it was at that point that people started looking at new technology for developing vaccines that could curb a future epidemic of the SARS virus. So scientists such as Kizzy Corbett, who developed the Mrna Vaccine, were the first people to pioneer some of this RNA technology. So by the time the COVID pandemic hit, the initial stages of developing a vaccine were already in train. And then there was a global effort to try and develop a life-saving treatment, which has so far claimed over 2.4 million people. And I think what was done at that point was, a number of governments invested, into development of vaccines. There were about 160 candidate vaccines which went through phases of clinical trials, and some of those candidate vaccines didn't progress from the initial phases of clinical trials to the bigger phase 3 clinical trials. So what happened was a lot of these clinical trials, the phase 1 usually is a small dose which is given to a small group of people just to check whether that vaccine or that medicinal product causes any side effects. And then there's a phase 2, which is a slightly higher dose, and it allows you to sort of test whether the vaccine or the medicinal product, is both useful in terms of being able to help prevent disease and is free from adverse reactions. A number of these clinical trials were carried on concurrently, which means at the same time. Usually with the different phases of clinical trials, what happens is that people complete the phase of the clinical trial, submit their scientific data to the regulatory authorities, and then that is analyzed before you can proceed to the next trial. But because we were in a situation where, we had a virus which was taking many lives and we needed to act at pace, some of this data was made available to the regulatory authorities quite early on to allow them to, to analyze the data and proceed to the next phase. The phase 3 clinical trials for any medicinal products take a long time because you struggle to find volunteers. Given the situation that we were in, and given the death toll, there were thousands of volunteers to take part in COVID clinical trials. And this was quite interesting in itself, because if, for example, you look at the way the hepatitis B vaccines were developed, only 1,000 people took part in those clinical trials to develop that, whereas tens of thousands of volunteers for the candidate vaccines that we've got were involved in the development of, the vaccines that we've got at the moment. So you're looking at about 43,000 for the Pfizer vaccine, 30,000, for the Mrna, and 24,000 for the Oxford vaccine. So before these vaccines were actually rolled out, their effectiveness and side effect profile had actually been tested in clinical trials. And as you can see from that slide there, the effectiveness of the Pfizer, Mrna, and Oxford vaccine is relatively robust, certainly in comparison, to some of the vaccines which are out there, which might give you something in the tune of about 60 to 70,000, for instance, with the flu vaccine. So just that should just reassure you about, the effectiveness of the vaccine. Now, the slide that I've just put up there, I'm expecting you to be able to recognize the scientific names there, but whenever a medicinal product, is made available to anyone for treatment in England and Wales and Scotland, the actual ingredients are included in the patient information leaflet, so you can see what exactly is in it. You'll find, for whenever even when you buy your paracetamol, it will have all the list of ingredients, it will have all the list of common side effects from the clinical trials, and it will have all the list of what we call contraindications, or conditions that prevent you from being able to have that medicinal product. There have been lots of myths on social media about this containing microchips, etc. This slide is just to show you what exactly is in it. It's also important to to point out that there is this number 3, which is the polyethylene glycol, which has been the one ingredient which has been associated with some of the severe adverse reactions, which we call anaphylactic reactions. And if you've got a history of, serious allergic reactions, it's generally recommended that you avoid the Pfizer vaccine. Just to give some context in terms of, some of the people who were involved in the development of the Pfizer vaccine, some people may recognize this scientist who was originally, born in Zimbabwe, who's gone on to work for Pfizer and was involved in the actual development of the Pfizer vaccine. Again, what's in the Oxford vaccine? Again, like I said before, it's an adenovirus vector. Does not contain, any elements which will cause actual disease. Does not contain any elements of, things like microchips, etc. I've put that slide there again to show what's on the Mrna, mRNA vaccine. Again, there's that, PEG, ingredient which has been associated with severe allergic reactions, and it's important if you have suffered from those that you use the Oxford vaccine instead of the Pfizer. I mentioned Dr. Kizzy Corbett in my initial discussions about how the mRNA technology was developed from the first SARS epidemic, and she's a very young scientist, an African American who was involved, and I think this should give some reassurance that this is not a conspiracy to exterminate Black people. So what's not in the vaccine? I often put this, there's no point me sort of encouraging people to have a medicinal product that I've not had myself. I've had the Pfizer vaccine. That was largely because that was the first one to be approved, and I was one of the first people to volunteer to have one. It doesn't contain microchips. It does not have any mechanism of changing your DNA or causing mutations. And as I've said, it does not. It's not part of any conspiracy to harm individuals. So one of the questions I'm often asked when I talk to people is, they're a bit hesitant about taking a brand new medicinal product, which which hasn't been tested, and they're worried about long-term conditions. I would always argue that with 2.4 million people dead, and with us needing to have a solution that's going to help us to get rid of this vaccine, to restrict access to the vaccine to only the people who are involved in the phase 3 clinical trials would be at enormous human cost. I'm just going to pick up the pace a little bit because my time has almost run out, but I just wanted to give some reassurance about the reasons why the intervals for increasing between the first and the second dose of the vaccines are justifiable based on the need to get the maximum benefit to the most number of people in the shortest possible time to save lives. Some people worry about fertility, and it's important to note that there is absolutely no evidence to support that the vaccine reduces fertility, and actually in the phase 3 clinical trials 23 women actually did become pregnant after receiving the vaccine. People always have a lot of concerns about long-term conditions. My advice is that the one clinician who knows your information better than anyone else is usually your general practitioner. If you do have some concerns and you want to do a little bit of reading yourself, this information is freely available on the gov.uk website. With over 12 million people vaccinated in the United Kingdom, a number of people with actually the long-term conditions which I've listed there have been vaccinated, and this was not actually a problem. So there is advice about people who are worried about their immune systems being compromised and whether it's safe to have the vaccine, and the responses that generally that is safe, and in fact those individuals are prioritized for the second dose. People have also been worried about the effectiveness of the vaccine in the over 60s, and this was largely due to the German regulators making a decision to only authorize the Pfizer vaccine in the over 60s. Again, the trial data actually tells us that the reason for this was that in the 660 participants in the phase 3 clinical trials of the Oxford vaccine, there were only 2 cases of COVID, and it was difficult to draw conclusions on efficacy. But what we do know is that about 2.9 million people who are over 65 have been vaccinated in the UK. It's definitely safe for use in that group of people. I think that comes to the end of my slides. I'll now hand back over to Harpreet to introduce the next speaker. Thank you very much for listening. Harpreet, I think you're on mute.
Oh, sorry. I knew I would do it. So I just wanted to say thank you so much for that. It was incredibly educational and informative. We've started to have some questions come into the chat box, so we'll try and pick those up in the Q&A in a little while, but please do keep sending through your questions. I'm going to move on to our second speaker then. So Dr. Habib Nakvi, welcome. Habib has come from the Race and Health Observatory and has an extensive background and career in equality and diversity, policy, public health and health psychology. I'm sure many of you will know Habib, as he was an integral part of leading the NHS workforce race and equality standards. So thanks, Habib, over to you.
Great, thank you very much, Harpreet, and thank you for inviting me to present at the East of England event. I think these kinds of events are really important. The more we have of them, the better. So the Race and Health Observatory has been now operational for a few months, announced last year by the Chief Executive of the NHS, Sir Simon Stevens, on the back of, in fact, the long-standing issues around ethnic differences in healthcare provision and outcomes across a range of different areas that span from neonatal health to end-of-life care, and of course in kind of every single kind of milestone in between those 2 points. And of course, you know, these disparities are set against the higher prevalence rates of some of the most common conditions and diseases that we are all kind of aware of: specific cancers, cardiovascular disease, diabetes, mental health. And of course, what we're seeing now and what we've been seeing over the last 12 months or so is the disproportionate impact of a pandemic, Covid-19, on Black and minority ethnic communities, which has shone yet another light on the ethnic disparities that we see across society as a whole. So there is a level of urgency to focus on the disproportionate impact of Covid-19 upon our communities, diverse communities, and I guess our country and our healthcare system should be well placed to focus on those or on that level of urgency, not least because we've got a long history of migration in this country. We've got well established and growing Black and minority ethnic communities. We've got robust legal frameworks in the Equality Act and the Health and Equalities Duties, and we've always had high level of investment in healthcare research, which has shown the outcomes, the positive outcomes in the Oxford vaccine. So the Race and Health Observatory is both data evidence focused, but also is solution focused at the same time as well. And what this slide in front of you now shows is I guess the 3 pillars upon which the observatory functions. Firstly, the synthesizing the insight, the rapid reviews, the data. Secondly, turning that into actionable recommendations for change. And thirdly, looking at supporting the healthcare system to implement those recommendations on the ground. And we put this model into practice a couple of weeks ago, in fact, when we brought together a small but kind of robust academic group to look at what is it that we need to do in order to push out kind of positive messages around the vaccination. We turned that into an infographic with clear policy and supportive recommendations, and distributed that out to NHS trusts, local community organisations and national arm's length bodies for wider dissemination. So we put that kind of that model into place quite effectively and pretty quickly a couple of weeks ago. We also wrote out to the JCVI around the prioritization of Black and minority ethnic groups within their timetable for vaccination, and highlighting sort of clear recommendations as to what we expect of the healthcare system around that. But the fact is that we cannot escape the very sad statistic that we have now of over 120,000 hospital deaths from COVID. But at the same time, what we can do is learn lessons from the previous waves of the pandemic and draw insight on the evidence on how the virus is impacting upon our Black and minority ethnic communities and potentially increasing some of the inequalities that we are all too familiar with. So we've seen the publication of a number of official reports since last March on COVID-19 and the impact of COVID-19 on Black and minority ethnic communities. And I guess what we need now is good planning or better planning and clear action to protect and prioritise communities that are most at risk from the disease. And of course, those communities that are most at risk also include our Black and minority ethnic communities as well. And we are, as an observatory, very deeply concerned about the vaccine uptake or kind of the lower levels of uptake amongst some Black and minority ethnic communities, and are focusing on, what is it that we can do, what is it that we can pull the trigger on quite kind of immediately to have a positive impact upon our communities, our diverse communities across the country. And so there is kind of a real concern around that hesitancy issue on part of some communities, but at the same time there is a huge effort that we're seeing now from the healthcare sector, but beyond that as well, involving community leaders, faith leaders, the way in which the NHS itself is administering the vaccine programme to overcome the level of hesitancy, to increase confidence levels and to increase the levels of trust amongst the diverse communities that we have. But amongst all of this, we must also remember that no community out there is hard to reach, and there is a need to focus on resourced, tailored communication and engagement aimed at diverse communities, and not just a top-down approach. I use my 73-year-old mother as an example, whose first language isn't English, and she will not, I know for a fact, logging on to governmental websites to review data in different community languages. So we need to kind of both a top-down but also a bottom-up approach to tackle some of these issues and challenges that we have. Tailored communications translated into those different community languages, but also using bilingual local authority, health and social care staff and volunteers within local boroughs and areas is absolutely essential for us as we move forward through people taking their first and now taking their second doses in some cases as well. I've always said right from the outset that is all good having banqueting halls and sports centres and indoor bowling clubs and race courses as vaccination hubs and vaccination centres, but we also need to be tapping into the temples, the mosques, the synagogues, the black churches that we have across the country, and it's fantastic now to see those venues, those community venues, being used as vaccination hubs and vaccination centres across the country. The other point I'd like to make here is around the issue of blame culture, because we know that a top-down, one-size-fits-all approach has in the past derailed countless well-meaning global health solutions, and in the context of vaccine implementation, it can risk leaving many groups behind, and that's why having a program, having interventions that are tailored towards the differential needs of communities is absolutely essential. Policymakers and communication leads are now beginning to understand this diversity, I believe, and are adopting comprehensive local messages and approaches that give communities a voice and the necessary resources to put ideas into action. So we are in a different place, I believe, today than where we were 4 weeks ago around the uptake, vaccination uptake issue with BME communities. I think we are turning the corner on that now, slowly but surely, but we need to keep up with that momentum as we go forward. And one thing that we cannot do is ignore the effects of injustices such as discrimination, such as racism, historical and ethical research and interventions that, together with the fake information and the misinformation that also is doing the rounds, appears to be impacting upon some Black and minority ethnic groups and communities, and that level of kind of mistrust and low confidence levels is there. We need to acknowledge those injustices and that level of discrimination in the comms that goes out, but also critically in the interventions that are designed and rolled out at local level. The final point I guess I'd like to make is around the fact that, as the previous speaker highlighted, is that the vaccines are safe and the message is absolutely clear. You know, over 16 million people have now been vaccinated in the UK. They've received at least one dose of the vaccine, and many are now receiving the second dose, those that were kind of the elderly group. The message is absolutely clear. You know, all vaccines have been through the regulatory and approval processes and are safe. They've been developed at lightning speed, but they've been developed at lightning speed to prevent wider transmission and death. And so this isn't just about kind of an individual making a decision as to whether or not that person will take the vaccine, but it's about the wider implications and protecting the health of your loved ones, protecting the health of your family and your colleagues, because the stakes are and the risks are far too high for vulnerable communities such as Black and minority ethnic communities to gamble the option of not taking the vaccine and potentially getting seriously ill or dying from COVID-19. And yes, we will have seen some of our family members, relatives, colleagues, even our own healthcare professionals, may have died or been seriously ill from the disease, but we should not feel resigned to the prospect of a negative vaccine outcome, and we need to act, and we need to act now on focusing on the positives, and the vaccine is a positive. It's a light at the end of the tunnel for us as we head towards the spring and the summer, and of course the roadmap that will be outlined by the Prime Minister later today. So on that positive note, I think I'll hand back to Harpreet to introduce the next speaker.
Brilliant, thanks Habib. I think that was incredibly helpful, and it's really fantastic to really hear about the support from the Observatory as well. And I really like that we finished on that positive note. It feels like the last year has been high level anxiety, so it's nice to see the positives, absolutely. So do keep your questions coming in, but I'd like to introduce you to our next speaker. So Ruth Adekoya works in NHS England and Improvement in the East of England as a senior advisor in the Integrated Care System Development Team. Quite a mouthful there, Ruth. She's a member of the NHS England BME Staff Network and Disability and Wellbeing Network as well. Over to you, Ruth. Thank you.
Thank you very much, Harpreet, and thank you for inviting me to be a speaker on the panel for today's event. As already mentioned by Harpreet, I'm a member of the BAME network at NHS England and Improvement, and I also volunteer as a policy and advocacy associate in that network. We recently set up the East of England region BAME network for NHS England and Improvement. And one of the key purposes of that network in our region is to create a safe space for BAME colleagues to share their lived experiences, but also to make it a space where sorry, I'm just getting a bit distracted, but also to make it a space where allies can learn about the experiences of BAME staff and what they can do to make our experiences in the workplace more positive. In addition to that as well, the network acts in an advisory capacity to the regional executive team in the East of England region, and also to the EDI group, so that's the Equality, Diversity and Inclusion group, and our workforce and OD committee on the BAME priorities in the region. Just like to say as well that the BAME network is open to all staff with a BAME heritage, allies, and anyone interested in driving forward race equality. So I've got a very, very limited time and to focus on three things today in my presentation, and they are the NHS Constitution, informed consent, and human rights. NHS Constitution, what is it? It sets out the rights of patients, the public, and what the NHS staff are entitled to. And it also includes pledges which the NHS is committed to achieve. It includes the responsibilities which the public, patients and staff owe to one another to ensure that the NHS operates fairly and effectively. I just want to emphasize that in the NHS Constitution Handbook, it states that a right is a legal entitlement protected by the law. And I just want to focus on three of those rights in the NHS Constitution. And the first one is that you have the right to receive the vaccination that the Joint Committee on Vaccination and Immunisation recommends that you should receive under an NHS provided national immunisation programme. The second right I also want to highlight is that you have the right to accept or refuse treatment that is offered to you and not to be given any physical examination or treatment unless you've given valid consent. If you do not have the capacity to do so, consent must be obtained from a person legally able to act on your behalf, or the treatment must be in your best interest. And lastly, you have a right to be involved in discussions and decisions about your healthcare and to be given information to enable you to do this. The point I'm trying to make is that you have rights protected by the law of this land, and you should not be shamed. You should not be ostracized or stigmatized when you exercise those rights by asking questions. Next, I want to talk about informed consent. So what is consent? In a nutshell, it's to give permission for something to happen. According to the NHS website, consent to treatment means a person must give permission before they receive any type of medical treatment, test or examination. It goes on further to say that consent from a patient is needed regardless of the procedure, whether it's physical examination, organ donation or something else. And for consent to be valid, it must be voluntary and informed, and the person consenting must have the capacity to make the decision. Now, there are exceptions to this, such as in an emergency, to save a life, and if is incapacitated. So for example, if they are unconscious. I just also wanted to point out that the GMC, so that's the General Medical Council, where all practicing doctors in the UK must be licensed and registered with, work to protect patient safety. And also the NMC, the Nursing and Midwifery Council, which is the professional regulator for nurses and midwives in the UK, and all nursing associates in England, all have principles around decision making and consent for members of the public and patients. But I just wanted to quickly highlight that the GMC has 7 principles of decision making and consent for all of their members. I'm not going to go through all the 7 because I do not have the time to do so, but I just want to quickly focus on 2 of those principles. And the first one says that all patients have the right to be involved in decisions about their treatment and care and be supported to make informed decisions if they are able to do so. And also all patients have the right to be listened to and to be given the information they need to make a decision and the time and support they need to do to understand it. I think you would see a running theme in terms of what I'm trying to say here is that you have a right to have questions, you have a right for your concerns to be taken seriously, and you have a right to receive answers to any questions you might have about the vaccine and how it affects you and any other long-term conditions that you have. Lastly, I want to talk about human rights. So remember when I talked about the NHS Constitution, I mentioned that rights are your legal entitlement. So in the UK, human rights are protected by the Human Rights Act 1988, and all public authorities such as the NHS must follow the Act. So this means that you can take action in the UK courts if your human rights have been breached. Have a sip of water. So the Act means the Act is there to protect everyone in the UK. It doesn't matter if you're a British citizen, a foreigner or asylum seeker, it's there to protect you. There are 14 articles, I believe, in the Human Rights Act, and it's got things like such as the right to life, right to private and family life, and right to freedom of religion and belief, etc. I just want to quickly touch on Article 9 and Article 10. Article 9 protects your right to freedom of thoughts, belief and religion, and Article 10 protects your freedom of expression. So freedom of expression, this means that it lets you hold opinions and express them freely, verbally, in writing, through television, radio, or the internet. But be mindful that there are limitations to these articles as well. So what are the key takeaways in terms of what I've mentioned about the NHS Constitution, your right to informed consent, and also your human rights? According to the NHS website and all of the documents that I've read so far, it states that the NHS is offering the COVID-19 vaccine to people most at risk from coronavirus. And I believe that there are different levels, and, you know, hopefully in a few months, everybody would have received the offer to accept an offer to get the vaccine. I just want to say that the operative word is offer. So when you are offered something, you have protected legal rights to either accept it or to decline what you are offered. You also have a right to change your mind as well. So if you decline it but later change your mind, that's completely fine. Most importantly, it is within your rights to ask questions and to be provided with evidence-based facts, unbiased information to help you to make an informed decision. And I'm really, really pleased with Dr. Ito's presentation at the beginning, where he's highlighted and really, you know, taken us through all of the different vaccines, the ingredients, etc. And I hope that's helped you all to make a decision, informed decision on whether to accept the vaccination when you're offered. One last thing that I really want to share with you is a BRAIN acronym. So it spells BRAIN, that we use in maternity to empower women to advocate for themselves. So the B is benefit. So when you're talking to your GP, you can say to them, what are the benefits of this vaccine? The R is risk. What are the risks to me? The A is alternatives. What are the alternatives? The I is intuition. That's more a question you ask yourself. What's my gut telling me to do? What's my intuition telling me to do? And finally, the N stands for nothing. What happens if I do nothing? Thank you very much for listening to me, and I'll hand over to Harpreet to introduce the next guest.
Thank you, Ruth. That was great. Thank you. I particularly like that BRAIN acronym. It was fantastic. I think it's really important. Ruth raised some really important points there about our rights to ask questions and really understand the decision that we're making. And absolutely right, this isn't a once in a lifetime opportunity. So if you change your mind, absolutely there's a way of going back and taking up the vaccine as well. So thank you very much, Ruth. I'd like to introduce to our final speaker, Ethel Changa. So Ethel has a wealth of NHS experience and has worked as a Deputy Director of Nursing at Hertfordshire Partnership University NHS, and has recently joined NHS England to support as a clinical advisor on the national COVID vaccination programme. Thanks, Ethel.
Hi, thanks, Harpreet. I hope you can hear me okay. Yes, fabulous. You know what? I'm so glad to be here today. What an event. Thank you so much, Tendai, and your team for putting this together, because I think this is really pivotal in helping us move things forward. I've been asked to specifically talk about reflections and how we can really reach out into our various communities. Now, I'm really passionate about this topic and what we're doing today, because I myself experienced COVID last year and almost lost my life, and therefore doing what we're doing today is actually something that I'm passionate about, and I'm also want to really encourage but also support people in making an informed decision in what they need to do around the vaccine. So without further ado, I'll start. I've got so much to say, so I'm sure Tendai will keep me a check with regards to my timekeeping. She's been so good so far. Okay, so I just want to echo the words which were shared by Dr. Habib there, which was act and act now, and I think that's absolutely pivotal and the exact thing that we need to be thinking about and to be doing at this time. Now, we know that there's been so many health inequalities and issues that have prevented people from actually wanting to take up the vaccination, and from where I sit and my perspective, a lot of the hesitancy is around historical things that we've experienced as BME and ethnic minority community, as well as things we've experienced historically and things that we are unsure about. So some of those things, as has already been mentioned, are around trust. So trust is one big thing. Do we trust the vaccine, and do people trust the vaccine? And these have been a lot of the issues that have arisen in our communities about actually how sure can I be about this vaccine. The other thing is really treatment historically, and again, it's already been touched on. We know that as an ethnic minority community and workforce, we have experienced racism, and we cannot run away from that. And things like racism and our past experiences are also causing a lot of people to get to that place where they're hesitant about taking on this vaccination. Misinformation, which has already been talked about, and we've been talking about for as long as the vaccine has been around. You know, what information is reaching our community, what information is getting out there. We know the information that is factual and correct, as has already been shared by Dr. Itai, but how is it reaching our communities? How is it landing in our communities? That is the question, and those are the things that we need to be absolutely working on as a team and collectively together. And then also the other thing is equitable access to the vaccine. Now, again, as I've joined different community groups and webinars and focus groups and really listened to what's going on the ground, I've come to realize that there are things like people without even an NHS number, people who are not registered with a GP, are asking, well, how do I get this vaccine? And it's those kind of issues that we need to start to streamline and issues that we need to address. Now, we know the non-NHS number issue has already is being addressed, and there's been communication which has gone out there to say that, look, you don't need this personal identifiable information for you to have the vaccine. But again, it's about how is it landing? How is it landing in our communities? Are people sure that that is the exact information? How about at the vaccination centers? Are they clear that this is not an ask for people? So again, it's about really triangulating all that so that we're absolutely clear and we're all working from one page. And that's one thing that we need to be working on. Now, touching on that subject, a lot of issues have arisen around people, like I've already said, who are maybe asylum seekers or homeless people, or people, like I've said, who are not registered with a GP. So again, we need to be really focused, but I think we're clear about the message, but it's about, are we all on the same page with regards to this information, and how is it reaching our communities, and is that causing an increase and in trust within our communities? Now, keep me a check on time, Tendai. How much time have I got? Only 5 minutes. That's not fair. I've got too much to say. Okay, I'll be very quick. Right. Okay, what do we need to do? What do we need to do? Now, everything I'm going to say is really based on some personal views, as well as what I've heard from the ground. You see, we need to take a bottom-up approach. We can't prescribe from the top. We can't be scientific about this. We can't, no amount of scientific information is going to make people change and start to trust and believe the system. We have to do something a bit more sophisticated than that. And one of the things that I want us to think about is generational beliefs. You see, there's generational beliefs embedded within our BAME communities. How do we change those beliefs? How do we change those beliefs? Beliefs about the treatment, beliefs about how we are perceived as a community. There's so many entrenched beliefs that someone needs to stand aside and really start to unpick those and really start to help our communities modify some of those generational beliefs so that we're able to penetrate those cohorts and actually get people to do the right thing around this vaccine. When we're talking about generational views, we're talking about family views as well. Within the BAME community, what the head of the family says is what the family does. So right now, as I'm speaking to communities, people are saying, well, those who've got relatives back home are saying, oh my goodness, my daughter and my son, do not take the vaccine, do not do X, Y, and Z. It's the father's voice that is speaking. When we address and focus on the family views and also start to reach out to family leaders, then we are a step in the right direction. So we need to tap into family leaders. How do we do that? Bottom-up approach. Oh my goodness, I've got 3 minutes. I need to put my skates on. And then loyalty. There's loyalty within families. So families are not going to want to go against what the head of the family is saying. Again, tag to that, we need religious leaders to be on board. We need them to come on board and be part of this whole campaign. So we need to address our to engage our religious leaders. One of the things that is being done in a particular region is when it comes to culture and religion, again, speaking as a woman of color myself and adapting, like for they've adopted things like women only section for vaccinating, or a women only day and things like that, depending on capacity. That has really worked wonders and has caused a lot of women actually engaging in taking up the vaccine. Why? Because as women of color, we have to take our sleeves down and, you know, exposure and things like that. So, you know, we need to be creative around this. And then lastly, us as BAME leaders, we need to be visible. We need to be visible. We need to go out there and be talking about the vaccination as we're doing right now. But we need to be visible on social media. Are we tapping into things like Team Halo, who are working with, you know, on a global platform to really get the messages out there? We need to be creative and we need to be smart in our approach. And the last thing, Tendai, before you mute me, is we need to humbly listen to what's going on the ground. It has to be a bottom-up approach, and we have to really really engage our communities based on what they're telling us and what they're saying, and yeah, and engage our stakeholders. I think my time is up. I think Tendai is going to mute me now, but I did have so much that I need to share, but maybe in the Q&A I can pick up some of those. But thank you so much for the time. Thanks, Tendai. Thanks, Harpreet.
Brilliant. Thank you so much, Ethel. That was incredibly insightful. You're getting some really positive feedback in the Q&A as well, so have a look when you get a chance. I wonder if I can pick up the first question with you, Ethel, just on the issues that you raised there about generational beliefs, family views, and what we can do to really start to challenge some of those, and really about that education piece. So what would your advice be to us as NHS workers and social care workers who are on the call? What's your advice to help change some of those beliefs?
Thanks very much, Harpreet. I think my solution is it's a simple one. We just need to apply our human factors. We just need to communicate. We need to listen. We need to engage these people. We need to engage the BAME communities. We need to engage them. The religious leaders, and we need to sit down and we need to listen and we need to take on board what they're saying. These are real fears. People are afraid of losing their lives. So we need to listen, but I'll put the word humbly in front of it. We need to humbly listen, and then we need to, while we're doing that, we're building the trust, and then we're starting to modify and help change those generational entrenched beliefs that are there. And I'll say that's our starting point.
Brilliant, thank you, Ethel. So I wonder if I can then pick up just a bit of a follow-up question with yourself, Habib. So there's a lot of questions in the Q&A really about some of the narrative around, particularly around Black, Asian and minority ethnic communities not taking up the vaccine. And some people feeling like it's actually stigmatizing our communities, and there's an element of pressure that feels that's now being applied. So what can we do to support our workforce and our communities in this space?
Yeah, it's a good question, and it's a question that's coming up quite a lot for obvious reasons at the moment. I think we need to learn more about about where we are with uptake, particularly amongst our Black and minority ethnic frontline staff in health and care. Once we've got that information, I think more up-to-date information around the numbers, figures, particularly at local level, I think we will be better placed to focus interventions. As I said before, the effects of trust, the lack of trust and discrimination and historical and ethical research and interventions cannot be ignored, and the fake information needs to be kind of tackled head on as well. But at the same time, I think we also need to remember that this it's not just Black and minority ethnic communities that are showing a level of hesitation. And of course, they should not be demonized for approaches that haven't really included their voice or perspective to date. And that's a really important point to remember. So when we're talking about not just top down, but bottom up approaches as well, we need the voices being heard, and we need people taking ownership around some of the interventions that we put in place. So, community approaches are beginning to have a positive impact, and we're beginning to see that now. And as I mentioned before, I think we are turning the corner with regards to uptake amongst some of the Black and minority ethnic communities. But the media has a significant role to play here, and I do worry that a negative blame game type reporting can potentially undermine some of the progress that we've seen over the last couple of weeks, for example. So yes, we are learning lessons, we are making a positive impact with regards to vaccine uptake, but of course there's a lot more work to be done.
Brilliant, thanks Habib, that's really helpful. I wonder if I can come on to Itai next, just some very specific questions around the vaccine and its impact. So the first one, and this one does come up quite often, is whether the vaccine affects people's ability to conceive. There was a specific issue raised in the Q&A about the vaccine affecting women's menstrual cycles. And I wonder if you had any comments on that, Itai.
Okay. So my one of my slides, I addressed a specific question. From the development of the vaccine, there's no evidence of its impact on fertility. The vaccine itself targets, the respiratory system, which is, your upper airways and your chest, and it's looking at a specific part of the virus, which is the spike protein, and helping you to build up antibodies, against the virus itself. In one of the phase 3 clinical trials in the development of the Pfizer vaccine in particular, women did actually get pregnant after receiving the first dose. So if you look at it from the point of view that usually when you are trialing a new medicinal product, which has not been made widely available, there's certain groups of people who are excluded from those clinical trial designs. Usually it's children under 16 and women who are pregnant and women who are breastfeeding. But what actually happens is that when you start a trial, you can't control what people do, and people did actually conceive during that time. And that tells us, that's sort of incidental information that we've got about, the lack of a negative impact on fertility posed by the vaccine itself. So, as I said before, in terms of the design of the vaccine, there is no evidence of that. In terms of, our actual experience in testing the vaccine, there is no experience of that. So I would offer that reassurance. Before, there was a caution about people, not having the vaccine if they were, breastfeeding, etc. And the MHRA have, updated their guidance on this because actually, the risks of contracting COVID whilst you're pregnant and whilst you're breastfeeding, supersedes, the concerns that were there before. And now that we've got more safety data, now that we've rolled it out to millions of people, we can be assured about these things. I think it's also important to mention, sorry, I'm going on a little bit, Harpreet, but it's important to mention that if you've got concerns about the vaccine, the go-to person is your GP. Your GP will have all your information, will understand the medication that you're on, and will be able to share a lot more information about, what are the next steps. And so I would really encourage people to feel confident enough to approach their GP and ask those questions, because we can only sort of dispel some of these myths by having conversations. And sometimes people like to have private conversations, and that there has to be a kind of targeted approach to addressing hesitancy.
Brilliant, thank you, Itai. So I wonder, I'm going to put this one out to the panel. So put your hand up if you want to answer this one. So it's specifically on the vaccine as well. So people are concerned about the COVID vaccine in particular, mainly because I think there's an element of pressure. That's what I'm picking up from the Q&As. But also there's a concern saying, well, actually, does this vaccine stop transmission? So will it stop me from passing it on? So what are the benefits of doing this? So which one of the panel would like to try and put something forward? Itai?
Yeah, sorry, I can't see the kind of, Teams etiquette, raise your hand up function. That's probably my IT skills there. But I think the first thing to say is that, even after we've received the vaccine, it's important for us not to be complacent. Once you've received the vaccine, it stops you from having the most serious forms of, the COVID-19 infection. You can still shed the virus without even knowing it, without even experiencing symptoms. So the vigilance around, the infection prevention and control measures, remain paramount. And, I'd advise colleagues to just be cognizant of that fact. And the important thing to say, though, is that when you have certain levels of the population, and it depends from infection to infection, of what's called herd immunity, your chances of being able to eradicate a communicable disease, is much better. So it differs from condition to condition, and that's all based on something called the R number that infection has, and the R number is basically the number of people that you are likely to be able to infect if you are infected with a condition. So if your R number is higher, then it means that the percentage of the population that need to have herd immunity needs to be higher as well. So this becomes an issue of us needing to work together as a community to try and eradicate a condition which has caused us so many problems, both economically, both culturally, in terms of mental health, etc. So that there's almost a collective call to arms here, really, which is about, yes, you may have concerns about yourself, and those are taken and accepted. But there is also, a sense of, duty to people that you come into contact with, your family, your colleagues, your community, and it's an individual, ethical decision that you need to make there. But it's one that you probably need to make with the fullest information you can get, and asking questions is a good way of doing that.
Brilliant, thank you, Itai. I wonder if I could ask a follow-on question then, just in terms of the uptake. So do you think it's realistic to have 100% uptake for the country? And what does that mean for personal choice, and how does that sit alongside herd immunity? So there's lots of issues that have come up recently about vaccine passports and what that means for how we might be able to get back to some sort of normality again. So how would you kind of reconcile some of that?
So I'll go back to that point about what percentage of the population do we need, and there are scientific papers that have looked at the behavior of the coronavirus infection in terms of how many people are infected once you've got it. It's also important for us to start to think about some of those things that I mentioned before about the new strains, and what we do know about some of the new strains is that they are scientifically more infected than more infective, as in the possibility of passing it from one person to the other is higher. So there's a risk there that if we don't get as many people vaccinated as possible, our chances of being able to stop this virus from mutating to form other sort of more more virulent strains becomes weakened. As it stands, the recommended percentage of the population that's required to be able to eradicate, COVID-19 sits at around 88%, or 90% if you want to round it off. But there's something to think about there. If if I decide that, well, you know, I can just be on that 10% and I'm not going to have the vaccine because the other people are going to do it and bring up that number. Imagine if we all made that, you know, decision, that number would rapidly reduce. So the emphasis really is about getting as many of us as possible. Wouldn't it be brilliant if we could get, you know, that 100% herd immunity? That would be us acting as a community to eradicate a condition that we know has taken about 2.5 million lives worldwide. That's a really big number. You know, the kind of human costs, some of the people who are coming down with COVID, you know, tend to be people who were sort of breadwinners within a family unit. And, you know, the impact of the people who are left behind is not just about the emotional loss, but it's also about, you know, the changed lives that have been affected by this virus. So there is a choice to make there, and I think it's one that's important for us to approach positively.
Brilliant, thank you, Itai. Ruth, I wonder if I could come to you next, really. So you talked a little bit about the BME network and its importance, but I wonder from your perspective, what actions do you think employers should be taking to encourage staff to be able to voice their concerns?
I'm sorry, Arprit, can you please repeat? I'm having lots of Wi-Fi issues, so I did not hear your question at all. Sorry.
No problem, Ruth. I was just thinking from your perspective, what actions do you think employers should be taking to really support their staff in their ability to voice their concerns?
I think employers really need to set a good example by creating a safe space for people to be able to ask questions and to let them know that there is no stupid questions and that people wouldn't be shamed or ostracized for asking those questions. I belong to lots of forums on social media, and it's absolutely disgusting the way people are attacked when they ask genuine questions. I have a set of autoimmune conditions. I've spoken to my doctors and they all give me conflicting advice, and I'm finding it really difficult to make an informed decision whether I should have this vaccine or not, based on my own health conditions. Many people have genuine concern. I know people who've got sickle cell, people who are on cancer treatment, you know, various conditions, and they've been shamed for asking questions to say, I'm a bit concerned about this, and you know, people come and attack them, or you're anti-vaxxer, etc. So, you know, if organizations really want to change this, they've got a crucial part to play in bringing professionals into the organization that can answer people's concerns with fact, and also let them know that their concerns are valid as well. At the moment, it seems like when you raise a concern, it's not valid at all. You know, so I think employers really need to set an example by creating forums like this, as we've done, where people can come in and express their concerns and hopefully get answers to help them to make an informed decision about whether to take the vaccine or not.
Brilliant, thank you, Ruth. That's very powerful. I think you're absolutely right. There's safe spaces to be able to ask the questions is really important. Ethel, I wonder if I could come to you next, please. So we had a question submitted to us before the webinar from an international nurse working in the NHS who's had COVID and is very scared to take the vaccine and has no family or support from their employer at the moment. So they feel very isolated, I think is what I was taking from that. And I wonder if I could just ask a second question as well, just so I can squeeze it in and you can answer them both. So the particular question around GP registrations or the lack of NHS numbers, just what's been being done around that to support people?
Okay, yeah, with the first one, with the person who has had COVID, I just want to first of all say to you that I totally understand your fears and your concerns, because I've had COVID myself too. But one of the things that would be helpful for you is to have a conversation with with people around you, your peers. Pick up the phone. I mean, where you work, I'm sure you've got, as Ruth has said, you know, we've got BAME staff networks. Find someone that you trust that you can talk to someone, and your fears are real, and I can understand them, because why wouldn't you be anxious if you've had COVID before? But what we do know is that this vaccine is here to give us that hope, so that we don't lose our lives, because I was at the verge of, actually, I almost lost my life, and I'm so grateful to be here today. And I see the vaccination as something that is really the hope that I needed. And for me, there's no two questions about it with regards to taking the vaccine or not. So if you want to reach out, I'm happy to speak to you, because I think when we can resonate and understand where we're coming from, I think it makes things a little bit more easier and helps us arrive at an informed decision. So that's what I can say to you. And then the other thing with regards to the non-NHS number, as you know, the government has put out a message out there that people that this is not a requirement for you to, in fact, what they've said is you can temporarily register with a GP to then have the vaccine, and it's out there, it's in the public forum, it's communication which is out there for everybody to see. So so go ahead and do that. So it's registration with a GP so that you can then have your vaccination. And there's still some work which is still being done around that to ensure that it doesn't open up, obviously, any other risks to the public or in any other way. But the general view is, and the general ask is, everyone needs to come forward to get the vaccine and be vaccinated. And we're trying to ensure that there's equitable access for all. I hope that answers the question. But if anyone isn't clear, I'm happy to kind of pick up the question further offline.
Brilliant. Thank you so much, Ethel. I think that, yes, if we can send some information out to everybody, and we'll put that with the recording as well of the webinar, and I can see there's lots of links being shared in the Q&As as well, which is fantastic. So I just wanted to say finally, thank you first of all to all our speakers. You've been absolutely brilliant, and there's some really positive feedback in the Q&A as well, so it's certainly been appreciated. Obviously, I'll take this opportunity to plug the future webinars that are coming up as well. So we've got one focused particularly around fertility, pregnancy and maternity on the 4th of March. And then on the 11th of March, specifically focused around international nurses and doctors, bank and agency staff as well. So finally, I really just want to say thank you to everyone who's been involved, Tendai and Harry, for pulling this together. It's been absolutely brilliant. I want to thank our speakers for their time and their valuable insights, and thank you to everyone for joining and for everything you've done and continue to do. So thanks everyone, take care, goodbye.